I'd like to really introduce our hip fracture registry golden hip winners from last year to talk about Dream Work Makes the Team Work. So I'd like to call Nicol Lightbody. Nicol is the orthopaedic clinical nurse consultant here at the Sunshine Coast University Hospital. And she's the lead investigator for the registry, and she's joined by Bethany Bolton, Stephen Murray, Nellie Dick, Sarah Griffiths and Glenn Tolano. And also just a reminder too, any questions that you may have on to go on Slido, that'd be great.
Thanks everyone. When we were asked earlier to do a presentation on teamwork, I thought the easiest way, obviously, to present how the team works is to bring the whole team with me. So we're just going to do it as a team.
Good morning everyone, my name's Bethany. I'm one of the senior staff specialists from the emergency department, the welcoming committee for the hospital, if you will. Today we'd like to tell you about Mrs Smith, who visited our emergency department. Mrs Smith is an 82-year-old lady who lives at home with her husband Clarence, for whom she is primary carer because he's legally blind. Unfortunately, Mrs Smith tripped over his white cane. She fell and landed on her right side on the carpet. She didn't hit her head, but she had immediate pain in her right hip and she was unable to get up off the floor. Clarence rang the ambulance and she was brought in to the Sunshine Coast University Hospital Emergency Department. Due to her pain, the triage nurse gave her a category 2, which meant she needed to be seen within 10 minutes of arrival. She's seen early by a senior medical officer who assesses her pain and refers to the Sunshine Coast Hospital and Health Service hip fragility guideline. She has some tests ordered and some medical imaging requested. This model of care enables that every patient is seen by a senior clinician early and has their pain and treatment started in a really expedited way. The pain is isolated to her hip region. She has no other injuries. Mrs Smith is taken to X-ray and from there into the acute bay where a bed becomes available. The geriatric emergency department intervention nurse proactively sees Mrs Smith. We call them Jedi nurses, and she's going to see how they've been getting on at home and what needs to be done for Clarence while she's in hospital. Mrs Smith has a background that's significant for atrial fibrillation and she's on rivaroxaban. She's going to need specialist anaesthetic and medical review prior to her surgery to plan her medical care. To expedite this care and to notify the many teams that are involved in the care of a NOF patient, a NOF page is released from the department via switch when the diagnosis of a NOF is made. The recipients of the notification are the duty anaesthetist, registrars from the pain team, the orthogeriatric team, the orthopaedic team, our ortho CNC, and the NUM of the orthopaedic ward. And of course Jedi, but they've already seen her in the department. Whilst she's in the emergency department, she has a catheter placed and a nerve block. Since our hip fracture network was established about 10 years ago, the rate of completion of nerve blocks in the emergency department's gone from 0 to almost 100%. The emergency department treating team complete an interim management plan. This allows the patient to be transferred to the ward, even if she hasn't been seen by the inpatient teams yet, and they will see her on the ward. And that's where we hand over care to our inpatient teams.
I'm Nellie, one of our anaesthetists here, and this is Dr. Murray. He is our
geriatric consultant.
So we have an awesome pictorial view here of Mrs. Smith's journey now. She's been through DEM. This just shows the cascade of events that will occur after they're admitted. From an anaesthetic point of view, lucky for Mrs. Smith, we have this awesome team and we've really shaken up our care of the NOF patient, including from the anaesthetic point of view, we have the redundancy, the paging system, so that referral from ortho to the duty anaesthetist can happen. The duty anaesthetist then arranges a review as soon as possible with one of our senior registrars, and then they will discuss with the duty anaesthetist or the treating anaesthetist. If they fulfil criteria for the fun spot, we'll actually know who the anaesthetist is the next day. You can see on this screen there's an evaluation of fun spot criteria that the patient will have to meet if they're going to get that first spot. So to make sure that these cases are done within the 48 hours, or now moving to 36 hours, we have these criteria that can be just ticked and flicked by our registrars, saying that there's no barriers to this patient going directly the next morning. Makes it easier for our registrars to say, yes, this patient fits this criteria. We are very lucky in having developed this fun spot, meaning first up NOF. So it's a dedicated spot on the trauma list, and we have almost at the point where we have 2 fun spots per day in our theatre, and we have at least 1 on the weekend. So that includes weekend days. So that's changed. It's been, world changing in the care of our anaesthetic of this patient cohort, because we can get those patients done first on the list. So I'm not going to keep going because we've only got a few more minutes.
And that's why we can also hope with this initiative of Fun Spot, and Sun is just second up NOF, so, second up NOF, we can hope that if the patients are reasonably stable, that they're going to be able to be transferred to the operating theatre before I even start my ward round in the morning. So all the medical registrars at our hospital understand this, well, not this criteria anymore, but the old criteria of, what's the of what's acceptable to undergo anaesthesia. If they don't meet those criteria, then they're going to meet me in the morning for medical optimisation. And I don't need to talk to you guys about the orthogeriatric model of care. We're lucky here at SCU that we have a very strong orthogeriatric model of care here, and all the patients are admitted under a geriatrician, with the ortho teams and the anaesthetic teams providing a consultative service, and that's on the weekends as well. So if they come in on the weekends, they'll also be seen by a specialist geriatrician. Will they manage their post-operative care, because that's when all the complications occur, and also expedite, discharge planning for these patients, either back to the nursing home for some form of restorative care, hopefully, or expediting their referrals to rehab services throughout the Sunshine Coast, be it public or private, and of course managing their osteoporosis.
And just as a side note, from the anaesthetic point of view, we also have APS that review these patients. They know of their existence in the hospital. They are alerted via the page, but then they are also they're checking up whether they need to be reblocked. If they haven't made that fun spot or sunspot criteria, then they'll be reblocked by our APS team. And our anaesthetic techniques focusing on regional analgesia, with trying to focus to get the early mobilisation happening post-op.
Perfect segue.
Hi, my name's Glenn. I'm one of the physiotherapists that work here at SCU, and Sarah, the num of the orthopaedic ward. I'd just like to acknowledge, first of all, I'm just one of the representatives of the wider multidis team here at SCU. Beyond the nursing and the medical staff, we have occupational therapists, physios, social work, dietitian, speechies, clinical assistants, and operational staff all involved with these patients. We engage in regular multidisciplinary team meetings to keep us on track and help problem solve some of the more complex discharge planning. We have a range of subacute pathways here across the facilities and transitioning into the community. We have a subacute liaison team that assists us with this, and a CNC Julie to keep us on track with those pathways. Ultimately, we prioritise mobility and early mobilisation, and as physios, we're available here 7 days to offer the day one mobilisation, but it's a team approach, and the nursing staff are of great assistance to us in trying to ensure that we give everyone an opportunity to mobilise daily. And over to Sarah.
Hi everyone, I'm Sarah, and Nick, who's the orthopaedic CNC. I just wanted to talk to you very briefly about what the nursing staff do in the ward. So when we know that a patient's coming with a neck or femur fracture, as Bethany and Nellie touched on, we get a NOF pager. Often Nick already knows before the NOF pager goes off, and if that's the case, she'll let us know, so we've got early notification. When the patient comes up to the ward, the nursing staff in the ward are responsible for doing a delirium assessment. So I do a 4AT on day admission and also day one. with a follow-up if it's required, depending upon how the patient's cognition might change during their stay. As Glenn touched on, the nursing staff are really good at early mobilisation, even if that's just making sure that patients sit out of bed for every single meal. And I'll cut out the rest of what I was going to tell you. They also do trial avoiding, they liaise with families, make sure they've got their hip fracture books, that they have any questions answered, and now Nick can take over.
Well, obviously, the glaringly obvious group that can't make it today because they are very busy are our SCU Ortho Golden Boys, we like to call them. They're our orthopaedic surgeons. Can't forget them. Sorry, this is taking a bit longer than I thought it would. There's many of them.
I did slow it down too.
That's perfect. There we go. So really, part of this presentation just does illustrate the tremendous teamwork that does go into the care of our hip fracture patients. It started in 2014, where a local hip fracture clinical network group was formed here, with representation from orthogeriatrics, orthopaedics, anaesthetics, emergency, allied health and nursing, both wards and theatre. We meet monthly, and we even embrace teams monthly during the COVID pandemic, and we just discuss any issues. We use the data from the hip fracture registry and come up with our new ideas and innovations then. We currently have 14 members. So really, yeah, as I said, as we've illustrated here, the care that goes into our hip fracture patients is from a team of many different departments and many different specialties that all come together. And we feel that this is why we provide excellent care to our hip fracture patients and why we won the Golden Hip last year. Thank you.